All right. Let's try this. Cool. Hi, everybody. I'm Dr. Italo Brown, emergency physician. It's a pleasure to be here with you all today for the AAEM Jedi MS4 lecture series. And my session today is entitled Social Emergency Medicine. I am an emergency physician and assistant professor at Stanford School of Medicine. I'm also fellowship trained in social EM out of Stanford. I highly recommend it for anyone who has an interest in doing work that extends beyond the emergency department and analyzes trends and issues related to care delivery, specifically for marginalized populations. All right, let's keep it rolling. So there are a couple of reasons why I love emergency medicine. One of those is I think that you're able to care for anyone regardless of their background, right? So you come in the emergency department, we are taking every single person. There is no discrimination. As long as you have a medical complaint, we'll see you. The other thing is that in emergency medicine, we are thinkers, doers, leaders, and communicators. All of these skill sets are encompassed within our role, and it attracts people who naturally have these abilities. So my colleagues have these abilities. It makes me feel like I'm around people who want to see change. So that's one of the reasons why I went into emergency medicine, and also why I love it. Some of the objectives of our lecture today are listed here. Let me go ahead and get into them. We're going to describe social and structural drivers of health. We'll give you the language of health disparities and health equity so that you are surgical with how you use it. We'll also understand how social drivers impact emergency care delivery. And then we'll describe social emergency medicine, its development in the real world applications. And finally, we'll discuss how social emergency medicine interventions improve health outcomes. So let's get into this language a little bit. I mentioned to you that it's important for us to use these terms with surgical precision, because ultimately this will determine how people receive the information and view you as an expert. So one, social and structural drivers of health. These are the non-medical drivers of health outcomes. I'm talking things like access, employment, insurance, right? Education, income, how much money someone makes, housing and transportation. These things are non-medical drivers, and they can significantly change the way that somebody experiences the healthcare system. Then there are health disparities, right? So health disparities, these are the discrepancies in health outcomes between two different groups. And those groups are typically along the lines of your, socioeconomic status or demographics. So you might see people categorized by race and ethnicity, gender, ability, any form of identity. And as I said, sometimes we'll use geography as well. And it's that head-to-head comparison. And when you see a difference between it, that's a health disparity. And finally, there's health equity. Health equity is this belief or expectation that every person, regardless of a group classification, can achieve optimal health outcomes. All right. Most recently, we've been hearing the words equity and equality almost used interchangeably. And for me, that doesn't quite work. I think what we need to do is make sure that there's clarity around the two terms, because they're not the same thing. Equality, this is realizing that everybody gets the same resources and it doesn't take into account any other factors. Whereas equity really does account for other circumstances, and that informs resource allocation. So if I were to use these two analogies in terms of a track and field representation, if I went down to a track and I saw all the numbers marched evenly across, that would represent equality. So all runners starting from the exact same position at this point on the track. But anyone who's run track and field knows that in a long distance run, the inner lane is a shorter distance than the outer lane. And so to account for this discrepancy, what we do is stagger the lanes. Staggering the lanes now represents equity. Got a list here of different things that I believe influence health outcomes. And I know this may look like a complicated graph, but what I want you to focus on is the column to the right, then we'll go column to the center, and then we'll talk about the far column. All right. So the column that starts with policies and programs and upward contributes to health factors, and then finally health outcomes. What we're speaking about is how the process of changing health outcomes can occur. Health outcomes are defined by two things, right? Length of life and quality of life, how long you live and how well you live. That next column over, where I have the circle highlighting, I want you to focus on the fact that there are percentage breakdowns in terms of the contributing or their contribution to health factors. Notice that they have things like physical environment, like the built environment, health behaviors, so things like tobacco use, alcohol and drug use, clinical things like how someone has quality of care, whether the facilities they use are up to par. But social and economic factors represent 40% of health factors that can influence health outcomes. That is a significant chunk. So more so than some of these other risk factors, more so than whether or not someone has air quality or water quality, we're talking about these same risk factors that I mentioned before that can affect the way that someone experiences the healthcare system and ultimately their length of life and quality of life. Now, we've all seen patients like this before, where there's an individual who comes into the emergency department because they need dialysis. And you might think about it as, why do they come here? They have a dialysis center, or they've known for a while that they are in need of dialysis. Why are they missing dialysis? Sometimes it's not straightforward. It's not just, oh, this person neglects their health or has apathy. Sometimes it is about complex situations, right? Like this could be a grandmother who watches a young child and the parent of that child has to work. And it's during the time where she usually gets dialysis. And so instead of finding a caregiver, she chooses to watch the child and misses dialysis, right? So that's a very complex social situation. We've also seen this middle picture here, the glazed look on a woman's face, or on a patient's face rather, where information or medical information and terminology are communicated to them in a language that they do not speak, that's not native to them. And for fear of embarrassment, they may not respond with, can you bring in an interpreter? Or do you have a translator? Or I don't speak English. We also understand the problems that the unhoused populations face in our United States, right? Tremendous, significant problem and tremendous difficulties there, right? But also understand that when they come to the emergency departments, they're often eschewed to the sides. They are typically deemed less important, given spaces that are inappropriate, sometimes aren't fully undressed to see if there are true other issues at play, and their medical concerns may often be overlooked. What about that patient who travels 30 minutes, 1 hour, 2 hours, sometimes even longer distances because the care facility that has the services that they need or the specialties that they need is nowhere near them? And so that barrier creates an issue in terms of them receiving adequate care, the distance barrier rather. We also know what it means to come in and have your rights stripped from you, because we see patients who are in custody essentially be handcuffed throughout their entire encounter and be treated subhuman to a degree, often having to advocate for them to be uncuffed and do an appropriate evaluation. These are all social factors that change the way that people experience healthcare. We also have a large migrant population. And so seeing that they often do not have adequate insurance, but are doing significant work is something that we have to keep in the back of our minds, right? Or whether or not their documentation status matters for them to even receive care in the first place. What about communities that are over-policed, that tend to see worse health outcomes because those communities have fewer resources, are not adequately funded? And these complexities exist because of underlying social currents. Or the picture that I have here of this woman who might have multiple jobs, right? She works multiple jobs part-time, and none of those jobs provide adequate insurance. And then finally, the unhoused sometimes work in communities, live in thriving communities, but those communities are often disrupted and they remain displaced because of certain policies that exist at the city level. All of these things land in the emergency department. And so when I ask you, what is social emergency medicine? It's essentially this confluence of issues and where we address medical concerns at the nexus of the emergency department. We don't turn away patients, but we actually address these concerns that are not purely medical, but may also influence their health outcomes. This is a quote by a guy named Harrison Alter. He says, in so many ways, perhaps more so than any other specialty in medicine, emergency medicine is enmeshed in the mores and practices of its immediate community, as well as the large social and regulatory milieu. It's a great statement here. It kind of encompasses what social emergency medicine is. So I know I gave you a bunch of terms, but if I had to give it to you in the simplest, most raw extract distilled form, I would tell you that social emergency medicine has these ATGC components, these 4 components that contribute to its DNA. The first is emergency medicine. So that is, your classic resuscitation, bread and butter, chest pain, shortness of breath, abdominal pain, all of these different things, nausea, vomiting, treating patients, traumas. That is one component, excuse me. The second is public health. So now we're thinking about health outcomes as they are represented at the trend level. So what are some of the outcomes that we're watching, the incidence, the prevalence? What do the statistics say about this? How can we make recommendations that change or build interventions that can change these outcomes or the patterns that we see? Then there's population health. So this is taking that data that is available at the state level, the local level, and trying to interpret it in a way that makes sense for defining policy, or specifically, how do you create better recommendations and interventions based upon larger data sets, looking at these statistics in from a closer lens. And then finally, health policy. So health policy, this would be taking all of those pieces and advocating or building local policy that supports some of these changes, figuring out how to shift the dollars, figuring out how to create resources to address the issues that are identified. The backbone of social emergency medicine really comes from 3 different areas, right? We've got social medicine, as represented here by this gentleman, Jack Geiger. He was one of the first persons that ever reported prescribing groceries to a patient, right? Because he recognized that nutrition was something that could significantly change somebody's health outcomes. But we also have global health. So international health, global health became really popular, and we start to see this uptick in people who go to these under-resourced areas and have to solve problems. That is a philosophy that carries forward into social emergency medicine. And then there's austere medicine or wilderness medicine. So taking very little resources and whatever is around and figuring out how to solve a problem, and possibly not inside of a clinical environment. All those 3 things contribute to the understanding of social emergency medicine. Why is it relevant now? Like, why are people thinking about it now? And it's because in the last 3 to 4 years, we've had this steady uptrend, which really broke in the pandemic, right? Where we started to see 2 things. Increased optics on epidemiology, increased concern around how this illness, COVID-19, was affecting different populations, and then understanding mortality rates and risks and all those other things, and realizing that at the same time, a social justice movement was skyrocketing because of the unarmed killing of Black men and women. And so these 2 things created a confluence where folks understood that there are unique barriers and unique threats to survival for people, as well as unique health risks. So I think that this all kind of contributes to the increased interest in social emergency medicine. Most social emergency medicine consists of one of these 5 things, right? So substance use disorder, housing, food or job insecurity, violence prevention, communicable diseases, or human trafficking. In practice, what that could look like. So I mentioned that you may have some type of screening programs or whatnot. One thing that we can do is offer medication-assisted treatment. So that is, folks who have substance use concerns can receive a medication known as Suboxone. We also have health desks, right? So health desks technically are basically resource centers, not physical centers, but virtual centers that are manned by people who are very well versed in social resources like food pantries, homeless shelters, or shelters for people who are unhoused. Know these treatment programs, understand where folks can go to get job recommendations and job services. Violence prevention programs, sorry about that. As is stated, these violence prevention programs seek to increase the support for people who are either the victims of violence or rehabilitate those who are perpetrators of violence. And it's all geared around trying to figure out the best strategies to equip them with knowledge and try to give additional resources. We have screenings, so whether it's risk at home screenings, our elders fall screens, their safety screens, those tactics are also social emergency medicine embedded. And then there's human trafficking. So the uptick in trafficking being reported has led emergency medicine physicians to use our space in a way where we can identify people who are at risk or are actively being trafficked, and then provide them with safety and other options and resources. I also encourage you all who are in the audience or whatnot to follow either one of these doctors. From the left, we have Uche Blackstock, then we have Megan Ranney, followed by Dara Cass, and then Dr. Wynn at the end. All of these women are extremely influential in the space, as you can see, highly diverse and very skilled. Here are a couple other pictures of folks who are doing pretty cool things in emergency medicine, as well as social EM. Alistair Martin doing registration for voting, Dula Pratt, who does essentially Stop the Bleed initiatives and teaches life support, like basic life support and life-saving measures to neighborhood youth and in South Side of Chicago. This last picture is me doing trap medicine with my team, where we are in barbershops and we go to local events to understand the health and wellness of Black men and boys. In the top picture is a guy named Mark Finnig, who started the Medical Justice Alliance, where emergency physicians partner with lawmakers and as well as attorneys to identify patients who are incarcerated who could benefit from having medical legal representation. For trainees, for the folks who are here, what I really want you to think about is you want to get exposed to social emergency medicine concepts, because this is the direction that healthcare is headed. The more we talk about this language, the more we teach and educate people that there is an inextricable link between social and behavioral factors and our environment specifically that we live in and our health outcomes, the better we are in terms of creating solutions that will improve these health outcomes, right? We will then also give rise to innovation. Like, people will naturally start to come up with these solutions and think of out of the box ways of providing care, providing better care, and meeting people where they're at. The final impact on these outcomes, right? So what I think about naturally is improved health outcomes. As I've stated multiple times, that when we identify these social drivers of healthcare and we are able to come up with programming and resources to support those things, the natural downstream result is people will enter the emergency department less because these other needs are being met. The other part is there's a return on investment, right? A financial return on investment. The cost of catastrophic care, you know, when things go very, very bad for patients who don't have insurance or who don't have all of those support factors, it is very high. And if we're allowing for intervention at earlier parts along that continuum, it will change the gross costs of healthcare. And then finally, systemic and structural remodeling. This is the belief that we start to put the patient first. We start to think about the patient as needing multiple things instead of just an isolated medical problem. And then finally, the entire medical system starts to look and shape around the patient almost like a web structure, as opposed to something where they enter in a single point. The social EM effect, this is, again, us talking about what happens when the entirety of emergency medicine and practice embraces social emergency medicine. It will lead to greater adoption. So people will start to understand that if you're going to be the best emergency physician, you have to know social and structural drivers of health. You have to understand health disparities. You have to understand health equity. And then on top of that, you've got to be able to teach these things laterally and downward and upward. Integration. All of our education should include some element or conversation around these social and structural factors. But more importantly, from the lens of emergency medicine, what are some of the common solutions, right? I mentioned those things earlier. How do we create violence prevention programs? How do we do better screening? How can we support those who are unhoused or who have food insecurity or job insecurity? These solutions, once integrated, can potentially change the way that we view the specialty altogether. And then finally, innovation. So realizing that we have some tools, but some haven't been created yet. And the more we embrace this, better ideas will come, because that's the natural course of emergency physicians, is to try to improve upon things and to consistently be curious and try to follow that educational pursuit. Finally, these are some things that I think are on the horizon, right? So we got to move beyond just tracking our progress on this. We've got to get to a space where we are able to utilize that data and activate that data to drive more resources towards social emergency medicine and to create a more robust workforce. So people like you who are interested in it early on and can become experts early on. Community engagement. So part of emergency medicine's major struggle has been to go beyond the realm of just the emergency department. So how do we take our services, things that are needed, and go into communities and become community partners rather than fixed pieces inside of a community? Finally, social justice initiatives. So we've seen over the last 2 or 3 years that more and more emergency physicians have taken a stance on social justice issues. And these things can directly affect patient care. You know, we see lives lost. We understand victimization. We understand issues of brutality and violence. And that lens that we have as emergency physicians make us very strong voices in the space. But we can also come up with programs to try to intervene, to try to improve, to try to solve some of these very, very tragic issues. And then finally, micro and macro level leadership. Micro and macro level leadership. What this means is we are seeing more emergency physicians being called into roles of leadership. Well, naturally, when we sit in these trauma bays or resuscitation bays and lead an entire resuscitation or trauma activation, we know what leadership is. But think about it at the policy level, when you see folks who are in office relying on the information of an emergency physician, or an emergency physician being appointed to a board to provide more insight on a problem that seems to be unaddressed or underaddressed. Ultimately, there is significant opportunity in social emergency medicine for people who are thinkers, doers, communicators, problem solvers. And I strongly encourage you to think about it as a career field. It's been a pleasure, you all. I'm Dr. Italo Brown. This has been an AAEM Jedi production. Huge shout out to those rising MS4s. I'm glad that you made the right choice. Now join Social EM. All right, take care. Peace.